Hello, my name is Jonathan Fritz. I'm the Chief Innovation Officer for Chime. It's my pleasure to welcome everyone to today's Chime Innovation Beyond the Edge. This series is designed to share creative problem solving in response to COVID-19 and highlight innovations implemented by your peers. Today's session is telehealth expansion as a pandemic response. This is our 9th Innovation Beyond the Edge session, and we've got 5 more planned. We've heard from a wide range of healthcare executives, with innovation being at the core for all of them. It's going to be an excellent presentation and discussion with Dr. Dorfler today, I can tell. A special thank you to Philips, one of the seasoned supporters and supporter for this session. We know you're incredibly busy at this time, so we appreciate you joining us today. I want to take a moment to just describe and talk about why Chime is doing this series. Change presents challenges and problems, but it also presents opportunity for creative problem solving. This is really what we believe to be at the core of innovation and want to celebrate the value and good that comes from it. Healthcare workers have faced many challenges, including those leading our health systems. Sudden remote workforce, spinning up, expanding, training clinicians on telehealth, infrastructure, resource constraints, now thinking about the second, maybe third waves of the pandemic. Planning and executing for the next phase of this war and transitioning to a new normal. What does that even look like? These are some of the challenges that our healthcare workers are facing. Thankfully, we're seeing just some of the most promising news today with recent vaccine trials and trial data that has come out. And there are many other innovations that are coming out to help us really battle this war. Innovation really isn't about bright, shiny objects, but it is about impacting and saving lives positively. And so we want to really highlight those valuable innovations. Before we get started with the presentation, I would like to cover a few details. Our session will have 3 main parts: a presentation from our speaker, 2 virtual roundtable sessions of 4 to 6 people, so everyone can have a candid discussion on the topic presented, and 3 Q&A with our speaker. First, we're going to hear a presentation by Dr. Martin Dorfler, the SVP of Clinical Strategy and Development and Associate Chief Medical Officer for Northwell Health. At the end of the virtual roundtable discussions, we'll bring everyone back together for a Q&A with Martin. If you're unfamiliar with the breakout rooms, that's okay. I'll provide brief instructions prior to splitting participants into the breakout rooms. We'll have everyone muted during the session, and if you'd like to ask a question, please use the chat function to alert the team. The chat window will appear on your right side panel. To ask a question, type your message inside the panel and press the send key. Questions for Martin can be posed in the chat function during his presentation or after we come back from the breakout rooms. I will ask the questions in the order that they were received, and we'll try and answer as many questions as possible at the end of the presentation. However, there is a chance we won't get to everyone. If that happens, we'll collect all unanswered questions and send responses via email to the attendee list. Also, we're recording this presentation. This will be saved and stored on the Chime site, so you can go back and review any details once we finish. Discussions within the breakout rooms will not be recorded. If you have difficulty listening to the live audio stream through your computer speakers, keep in mind that you can connect to audio via phone. If you need help with that or any other technical detail, please use the chat window to send us your questions. For those connecting via phone and your computer, please message the host with your name and phone number. Our host will then merge your phone and computer connections. Lastly, by attending today's full session, the presentation, and the virtual roundtable discussion, you will earn 1 continuing education unit for CHCIO, CFCHE, and CHISL certifications. We will review the attendee list following this session and distribute CEUs accordingly. With that being said, I'm going to hand it over to Karsten Russell-Wood with Philips. Karsten is the portfolio leader for post-acute and at home, and he leads innovation and cross-business platform strategy. Philips has been a great supporter and partner of Chime for quite some time, and we appreciate them being our Innovation Beyond the Edge seasoned supporter. Karsten?
Thank you, Jonathan. And really the words that you said there touched me as we speak about innovation. And I think of famed oceanographer Edie Witter, who said, exploration is the engine that drives innovation. And of course, innovation drives growth. And really, that's what we're going to hear about today. We're speaking with Dr. Martin Dorfler, who comes from Northwell Health, and really just phenomenal organization that I'll bring into light here. Northwell's experience during COVID-19 has emerged as the national response benchmark relative to uniting people, process, and technology to support patient care in the hospital and the home through its own 800 plus hospital and care center locations, but also in support of some of the temporary hospitals and coordinating the state's response. Over 40,000 COVID patients in the state of New York were treated by Northwell. Northwell also has been on the forefront of sharing their thought leadership and innovation, including outcomes, new solution use cases, and clinical systems engineering. One such experience was the enhanced interdisciplinary nature of care teams working across care venues, as shared by CEO Michael Dowling. It's also my honor to introduce Dr. Martin Dorfler, who serves as the Associate Chief Medical Officer and Senior Vice President of Clinical Strategy and Development, and is responsible for guiding the advancement of clinical care for Northwell. Dr. Dorfler is a critical care physician and is an early innovator in telehealth, both from the perspective of being a leader in the clinical informatics and virtual care industry and transitioning for the past decade as a leader at Northwell Health. At this time, let me sincerely welcome Dr. Dorfler. Thank you for being here with us to learn how the system response of Northwell has led rapid scale and expansion for this pandemic. Dr. Dorfler?
Thank you, Karsten. And hello, everybody. I would say good afternoon. That's where it is here on the East Coast of the US, but some of you probably are not in the afternoon right now. Move through this with reasonable pace because a fair amount here to cover and an awful lot done. This is what Northwell Health looks like on a geographic map of the downstate New York area. We're concentrated on the western part of Long Island and all of New York City. Those of you who have paid attention to the focus of the pandemic, you've seen Elmhurst Hospital on the news. Elmhurst Hospital would sit in the middle of those, that bunch of H's that's to the left of center. We've got multiple hospitals surrounding them, and our Forest Hills, LIJ Valley Stream hospitals in that same area were similarly inundated. We actually transferred about 800 COVID admissions out of that area farther into our system. As Karsten said, I think we're approaching about 50,000 cases of COVID-19 that we've treated so far. About 15,000 of them admitted to the hospital. We last Sunday had our 10,000 live discharge. Still have roughly 1,000 patients in-house. So obviously we've had a couple of thousand deaths and all of that. Northwell has 23 hospitals. We have 72,000 employees. We have 2 million individual or distinct patients that we touch annually, with about 5 million total touches. So it's a pretty good sized place with the largest market share in the New York downstate area, and actually the largest employer in the state of New York. Number of things going on prior to this, and a little bit of it summarized on this. We do have a tele-ICU. It is built on the Philips infrastructure. We've used that infrastructure more broadly than the original concept of EICU. Most of the things that are on here are telestroke program, where we have our stroke neurologists wired in their homes and offices on the Philips system. We've got an skilled nursing facility program that was originally on the Philips system. We've since transitioned it. I'll show some of this deeper into our American Well system. We have an hospitalist program focused on our emergency departments that was prior to COVID, focused principally on accelerating the transition from emergency decision to admit to actually beginning to receive inpatient care. We have an EICU outpost in our pediatric hospital in the ICU, and we have the pediatric critical care people there as an adjunct to our 24/365 EICU program, attached to a number of our emergency departments and pediatric units around the system for consultation. We have a similar structure. We have a 24/365 neurocritical care unit, and we have that staff available again through the same infrastructure. Everywhere we have the Philips software. We've got several of our trauma bays wired that way. Our telepsychiatry program actually is not on that system. It began on Cisco Jabber with Cisco DX70s and transitioned to the American Well platform last year. And so a variety of things here that are in existence prior to the outbreak. This is a little bit of our footprint as to what we looked like at the start of 2020. This slide was originally with some minor modifications created for our budget process, which closed out in November. So the telepsychiatry program, the red boxes around the hospitals were places we were planning on bringing up in 2020. So you see telepsychiatry, telestroke, the tele-ICU, telehospitalist. Telecritical care, differentiate that from tele-ICU, is a consultation model as opposed to the central team model of tele-ICU, and then telesniff, including turning on our first external customer. We sell our services to some affiliated institutions, same thing with the tele-ICU. The Wyckoff Hospital there is not a Northwell facility, but is a partner facility that we sell services to. And this slide's worth paying attention to from the standpoint of quickly moving to the changes in the pandemic. H.H. Huntington Hospital there was partially wired. We had not gone through the clinical implementation process. We turned them on very quickly. Instead of taking a couple of weeks to bring everybody up with all the processes fully worked out, we just flipped on the switch, began assisting them with care. The Peconic Bay PBMC there was moving into a new tower. We were waiting for that move to occur. That move occurred in 3 days instead of over a couple of months it otherwise would have, so we could immediately turn on our support for them. Staten Island University Hospital, we were actually in the process of starting to wire them. It got shut down by this, and we had to work with carts with them on a more critical care model than tele-ICU model. And Phelps was ready to go, but didn't have staffing. We flipped the switch with them. Similar with the stroke and psychiatry and the other situations, although not all of those are as formally up right now. We're doing some ad hoc stuff there, but we turned them on, these all on very quickly. To just add in that in addition to the stuff we had in place and we're working on with Philips, our direct-to-consumer and office-to-office product that we are using is made by American Well. We're actually not on what I call native American Well platform. We had started working with a company called Vizia about 3.5 years ago. They were acquired by American Well 2 years ago, and so we're still on that legacy system. And we had purchased about 30 of these Model 250 carts in November. They showed up in January. We were pushing those out. We had actually budgeted 90 more to be rolled out as part of our expansion of telehealth into our broader in our EDs and med-surg spaces. We've now rolled out another 40 of those, and I have another 50 coming in that will continue to roll out, particularly under our hotspots as we prepare for the fall, which I do expect. And we're focusing a lot of energy in our system on being ready for the fall, where the COVID pandemic is going to overlie with the annual flu process, which we expect to be a problem. There's a couple of slides here, and you'll get these slides afterwards, so I'm not going to go through each and every one of them here right now, but each of our hospitals, and we're broken into 3 regions, Eastern, Central, and Western. So each hospital, I think part of a piece of these 3 slides is that every hospital had different existing infrastructure, and every hospital had different needs, and some things we needed to do on a system level. So for instance, Glencoe at the very top of this, and I won't go through every single one of them, is now we're creating an LTAC there for patients that we can't get out of our tertiary and quaternaries because of their long-term ventilator needs. Just to back up, we have about 500 adult ICU beds prior to this, and at the height of the pandemic, we had 1,200 adult ICU beds. We normally have 300 to 400 patients on mechanical ventilation. At the peak of this, we were at 1,100. We're now down to under 1,000 COVID patients in-house. We still have about 400 or so on ventilators. So trying to get back to normal means that we reposition patients into optimal care delivery infrastructure. And so even creating palliative care through our telehealth infrastructure is there. Telepsychiatry, we did not have an inpatient COVID positive location for psychiatric patients. And so we created one. Talked to the behavioral health service line, insisted that they had to pick one of their 6 inpatient locations. We actually have two dedicated behavioral health hospitals. We chose not to do that for a variety of reasons, and we moved carts there. Those carts for telepsychiatry, because we could do it, were our Cisco DX70s, which you may know are out of service, but they work perfectly fine for face-to-face. They don't have the pan-tilt zoom that we have on the carts that we'd previously put in place under the Philips infrastructure, which on here say ECM for eCare Manager carts, or the carts we've just rolled out with American Well. And I would actually say one of the real flexibilities of all of this is to the extent you have the ability to put PTZ mobile carts out into your environment, they provide a phenomenal flexibility around what you're doing. You'll see here, and I'll focus on the telehospitalist part of this here, we put carts out and connected our telehospitalists, and they actually moved multiple times. On day 1, they were focusing on admissions in the ED. On day 2, they were focusing on COVID positive or suspected patient admissions in the ED. So we began to try to use protection, use our telehealth program as a way of minimizing exposure of our staff. We've always had adequate PPE, although adequate is a matter of judgment. And so all along we've been trying to minimize the unnecessary entrance into rooms. We have one person go in, everybody else on carts. Our carts were always used in a central model. We began deploying them for use by the bedside teams to, again, minimize going into the rooms. The ICU expansions are on here. Lenox Hill, we closed down, opened up a psych unit, closed down a psych unit. Again, you'll see that these carts moved around quite a bit. And then we were not part of the initiation of the Javits Center, but as it progressed along and was not actually accepting COVID positive patients, when it did, the governor asked our CEO, Michael Dowling, who's been a principal advisor to him on healthcare, to assist with the management of that. And so we did, as the military began to pull out towards the end of the time there, we moved our telepsychiatry program in. We normally spend 2 or 3 weeks to do that. We did that in 3 days. And they assisted with the psychiatric behavioral health needs of the patients that were there. The patients in the Javits Center did not require ICU care. The vast majority of them, if they'd come from homes like I live in, would have gone home. They were generally a population did not have high quality residential opportunities to go to, needed to be hospitalized to continue their care and support, and keep them from infecting others in their environment. And so their needs needed to be attended to. And then the Wyckoff piece on here, we were in there with TeleICU. They were actually the first. They were the first death in the state of New York. I diagnosed that case in the ED when they first came in remotely. We supported the staff there who did not pick it up at first. One of the big pieces to the remote team and all of this is the ability to focus on staff protection. And we could spend a lot of time on the role of virtual mixed with on-site care as the right mix. We began to pivot in the EICU from bedside documentation by nurses to remote documentation by the tele-ICU nurse team supporting the bedside, a variety of things along that space. And I know I'm going through this quickly. There's a lot here to cover for the 20 minutes, and we'll obviously have time afterwards. The pivot here into what we were doing with our American Well platform, and we saw this really as this dial where the patient could be somewhere, any variety of circumstances, and a provider anywhere, and you just turn these dials where you could have a pediatrician caring for a sick child at home, or you could have a social worker, assisting with an elderly patient in a skilled nursing facility. One of the advantages of this platform for us is we can have multiple people in the same time. So I could actually have the social worker and the surgeon and the elderly patient and her daughter in another town in there. And so we were working with this platform. And again, part of the luck we had in this is that we were already rolling some of this out. Part of the misfortune we had is we didn't have it all rolled out, as some places were already more mature. And I'm sure across the audience here, you're in all sorts of different settings to all of this. On March 1, when we activated our emergency operations center, we had, as you can see on here, about 500 individuals who had access to our American Well platform. We've got two different versions of the platform. You'll see that on the summary of this that will be shared with you after this is all over. About half of those were our staff. We were just beginning to do some care in this model. We were doing about 150 virtual visits a month for the previous 6 months. We're projected, just as a matter of comparison, we're projected to have 65,000 completed visits in the month of May. We had 45,000 in April. We began a very rapid process to scale, and you can see here by on this slide, by 4/11, we had brought up 5,400 individuals with basic access to our American Well platform. This slide here carries you forward even farther, and you'll see that right now we're somewhere around 6,500 individuals, starting to spread this out to house staff and even our medical students to begin giving them access. In here are embedded 800 behavioral health providers, 600 internal medicine, pulmonary, et cetera. We actually, important to recognize in terms of scaling for a pandemic, we began by focusing on primary care, medicine, OB, geriatrics, pediatrics. We then, and that was the first week. The second week, we began to focus on those caring for vulnerable populations, so oncology, transplant, rheumatology, pulmonary, heart failure, a variety of things along that line. And then we began layering everybody else, and even now we still have some folks coming out of the woodwork who didn't know what was going on where, and the like. We didn't reach them all earlier on, and so we still have some practices coming up into this. Those are the slides I'm going to go through here, but sort of talk about this process, because this actually became quite significant. Even though, our size is large by numbers, it's a small geography, though on a busy day pre-COVID, when the roads were busy, going from one end of our organization to the other could take 3 hours in traffic. It could obviously be quite significant. We had to set up, we had to push out headsets. My telepsychiatry program, we found that our psychiatrists were keeping them attached to the device and sharing them as the shifts went over. Well, what do you want to do in a pandemic but pass around the device that's attached to your head that you're spitting in all day? So we purchased, over the course of this, some 3,000 headsets. We purchased somewhere around 2,000 webcams. We had to set up a distribution network to get those out into the regions, from the regions out into the local hospitals, from each hospital out into each provider group. We issued probably another 1,000 laptops through all of this. We purchased the American Well carts that I mentioned to you, and some of those are still coming in, and we put together a leadership team of a regional exec. Our regions are run by a regional executive director, reports to the system COO, a direct representative of the regional executive director, a critical care service line lead for each region, and then 3 members of my team. And twice a week, they would get together and decide which carts went where and how they needed to be moved around and who needed to get what devices and in what order and all the rest of the sort of stuff. So it really is something of a true rapid scaling of whatever capabilities you have, but also a very flexible infrastructure to be able to move things around as demanded by the needs of patient care. I'd be really happy to be able to answer questions when we get back to it. I'll stop here for the moment as a summary of all of this. We can break out if that's the next stage of this, and then come back and maybe have some dialogue as a group as to how this might fit into your environments or be different than what you are capable or think is the right way to go with some of these.
Thank you very much, Martin. Martin, I've got a first question. Obviously, there's a lot of work that went into quickly spinning up telehealth capabilities. Do you see anything in particular, any particular types of innovations that could help sustain that or refining that? And are there, internal allies at your organization that can help with expanding that?
Yeah, so what we spun up really fast was a workflow model of, I refer to as point and shoot. I mean, basically sending out a link to somebody through text or email that they can click on and be in the telehealth session. What we were working on, and we're now working on to get some of the kinks out of it, was a fully integrated model. So with our broader platform, we have inline language translation. We have synchronized with our Sorian scheduling system. So you can have that visit scheduled in advance. The patient can be in a virtual waiting room. The provider is not sending out a link, waiting for the patient to click on it and then coming in and losing 3 to 4 minutes, extending the visit time. They're in the link sent out in advance. The patient, we actually have our digital patient experience portal. The patient can schedule that virtual visit. We actually changed our scheduling system in the past, and we're now beginning to roll out so you can schedule 2 providers simultaneously, which is no reason to do in a face-to-face world. So that you schedule your visit, you're in the virtual waiting room, the provider comes on, the encounter's already been created in the EMR, they're documenting in context. The fact that they're documenting in a templated telehealth note maps all the way off to the billings infrastructure, and the charge drops no different than if they had been seeing a patient in their office. The future of this being successful and sustained within the provider community is going to make it as seamless as possible. We're pushing out dual monitors so that they can be documenting on one monitor while they're seeing the patient on the other, as opposed to trying to toggle back and forth on the same window. From the patient standpoint, they're not going to give this up. Access and ease for the patient, instead of them getting in a car or a bus or whatever it is and spending 30 to 45 minutes, an hour getting to a provider location, sitting in a busy waiting room for X amount of time, seeing a doctor for 15 minutes and then going back again. They spent 3 hours for 15 minutes. Now they can spend 15 minutes for 15 minutes. And so I think the patients aren't going to give it up. What we really need to focus on is to have it as seamless as possible for the provider community, so that they are able to go from a face-to-face examination of a patient in an exam room to walking into the other office and sitting down at their screen and seeing the patient who was waiting for them there, letting them come in and having those both feel exactly the same. If we can get to that, which is what we are working on, this will not go back, and everybody are going to be happy, including the improved care that I think it will be created by it.
Excellent. Carson also asked a question in the chat function that is very much in line with this, and looking at how is telehealth really going to change with how PCPs and patients interact. And it also brings to mind, one of our previous sessions, we had Dr. Natalie Pagler at Stanford Children's, and talking about how, from a pediatric standpoint, that the interaction between the patient and the physician, and especially being a child or younger, and to be able to not have that physical touch, but still interact. So thoughts on as this expands, how the PCP and patients will interact in those changes?
Well, I would be shocked and disappointed if we move to a predominantly virtual world. Healthcare does need to have touch and more than touch, a lot of other interactions that are part of being in the same room together. Children of different ages are going to have different elements to that, and the nature of the problem is going to be different. Pivoting to an adolescent with a behavioral health crisis, our experience is they actually prefer talking to a screen than to sitting in a room with somebody, especially when you get the individuals on the spectrum. Take a young child who needs to be held to calm them down, on the other hand, that's not going to work. And so these are going to be very different pieces to that. But I'm going to pivot it slightly different into those interactions. One of the things that came up, we have a new chief of cardiology, just came in a few months before all this, perfect timing to come into someplace. And he said, he and I were talking about, he said, my docs are now used to doing some of their care from home. He says, is there any reason why I can't start going to 7-day-a-week appointments? And the answer is no. And so I think, again, there are going to be some of those type of things. But even before this, what we were looking to do in that direct-to-consumer space wasn't all problems. We were going to start, we had started this on known patient, known problem follow-up. And I think that space is ripe for this and could easily be 90% of care. New patient, new problem, I don't know anything about. That's going to probably, once people get comfortable going back into doctors' offices on a regular basis, that's going to pivot back to being face-to-face. And some of the things of the virtual urgent care world that where we see over prescription of antibiotics and those kind of things, we're going to avoid by using virtual care for situations that are very clearly capable of receiving the same or better care. We're going to have more touches with patients as opposed to fewer. But I don't think we're going to come anywhere close to eliminating the appropriate utilization of real, in the same room, physically connected care.
Thank you. We have another question. Are you considering the use of virtual COVID clinics for high-risk patients, such as obstetrics?
Such as obstetrics. I'm not aware of us looking at virtual COVID clinics. We have set up, certainly during the crisis point, we have screening virtually to move them off. We have our own laboratory infrastructure. We're full suite. We have EMS. We have home care. We have everything that's there. We just pushed out something called LabFly, which for $15 will send a phlebotomist to your home, draw your bloods, and you don't even have to go anywhere from there. And so we are trying to minimize patients coming into other settings. We are looking not so much at virtual COVID for obstetrics, but we are looking at setting up obstetrical delivery locations that are outside the main hospitals to a higher degree, so that we can make those moms that much more comfortable that they're likely to be in a COVID-free setting. We've turned 2 of our smaller hospitals right now into surgical facilities only for those urgent services we're allowed to give. We're still under governor lockdown issues in terms of going back to complete normal. So we are looking at some level of segregation. We're looking at ward segregation and the like, and part of how we'll use the mobile carts as we move along is to enable everybody who needs to see a patient, but if they're just flitting in and out for brief elements of care and don't need to put their hands on somebody, those will be virtual in those settings. So the mixture of virtual with what I'll call hands-on care is going to continue to evolve. But the specific piece of COVID selectivity under obstetrics is not something that I've heard in our discussions yet.
Okay, thank you. One last question before we wrap things up. Are there any specific COVID-19 related friction points that you or your team came across that you'd like to highlight as far as innovation is concerned? Any creative problem solving as a result of those friction points?
Friction points, as with anything, there are groups that are innovative and there are groups who aren't. And, the friction points that I had prior to this, some of them we talked about around the ICU and, some of the natural resistance to change in some individuals there, but globally at the system, it's been fine. My hospitalist organization has not been innovative. And I've been trying for some time to get them to take ownership. And the telehospitalist program was created by telehealth. You might think that it was created with the hospitalists, but it wasn't. It was created to solve a gap in things going on there. And so, trying to get that leadership group to actually embrace the future and revision their workflow with new tools is moving very, very slowly. And I'm probably going to use our budget process as my next lever in all of that. Now that they have developed some level of dependency on services that we're providing that they previously saw no reason to have exist, to move some of those things along. But the reality is that classic friction points have largely been suppressed during this. We still have the occasional malcontent surgeon who's, everybody's bylaws require you have at least 3 surgical curmudgeons somewhere on your medical staff. They still exist. And they're still coming forward. Some of them are specialists, not always surgeons, and trying to be disruptive. And they see that this as another tool for that disruption. But I try to teach my younger folks to be patient, and by and large, they'll get frustrated with not listening to them, and they'll go away. And I think the same will be true here.
Well, Dr. Dorfler, I'd like to thank you very much for the presentation today. And also I'd like to thank Phillips and Karsten Russell Wood for your support of Innovation Beyond the Edge.